dear colleagues, friends, esteemed faculty, and thank you so much for having me here. Especially a lot of thanks to Ram sir. I'll be speaking on specifically, Ram sir asked me to speak on advances in the SEA. I work at Manipal Hospitals, Whitefield, Bangalore. So thanks to the master who's taught us all about SCR, and our understanding of the SCR has come from the understanding of the anatomy. So anatomy shows that the average capsular insertion would be around 4.4 to 9.1 millimeters, a pretty thick capsular insertion on the GT. And then we also know that the capsule is very important for stability from multiple papers. Then considerations in an irreparable tear would be like, if we have irreparable tear, we have a tendon retraction, inelasticity, muscle atrophy, and fatigue infiltration. And then we went on to quantify this with classifications like this and like this. So now we know how to make out an irreparable tear. So now coming to the SCR works on three possible theories. One is a space effect, the other is a trampoline effect, where it prevents any proximal migration, and then the last would be a force coupling effect, where when the muscle heals on the remnant muscle heals onto the graft, there's a pull of forces, and then again it acts as a depressor. So here, then with all this in mind, Mihata went on to his first paper in 2012, and which was a biomechanical study, and which showed that an SCR definitely works well, decreasing the subacromial contact pressures, increasing the AHD, and restores the pleurohumeral compression pressures. So now, he again, 2015, 2013, he went on to have multiple papers with outcomes, showing excellent outcomes regarding the scores, range, and he had very less number of retests. Then, now I'll go into the advances over last many years, what has happened in SCR. Coming to I thought I would divide this into two categories. One would be like the clinical outcomes, and the other the biomechanical outcomes. In the clinical outcomes, when we look at the outcomes of Mihata, because most of the facial data papers come from Mihata, he has excellent outcomes considering the ACS scores. Increase, that is the AHT has increased, and very less number of retests. Personally, the retest is pretty less. He also gives excellent outcome when it even comes to pseudoparalysis. This is from this 2013-2018 multiple outcome papers. So then, now if we compare this to the dermal allografts, we find that there are certain differences, subtle differences, which are there are definitely improved ACS scores, but not much increase in the AHT. There are higher repair rates and better healing and function was noted in grafts more than 3 mm in thickness. So these are the transient findings when we compare the two groups. And then we come to the 2020 paper from Bakhat, where it's basically on dermal allografts. He says that the clinical outcomes are made in over 2 years period. So these are encouraging outcomes, and these are the already papers which I've discussed regarding the dermal allografts with excellent outcomes over 1 year follow-ups and all that. Coming to biomechanical outcomes, so Mihata started working on the biomechanics and tried to understand more on this, especially in 2016 paper, where he discussed on the side-to-side repairs. So side-to-side repairs, it was understood from his papers that if it is always better to have side-to-side repairs, and the posterior side-to-side repair is the most important. Now, let's look into a little more on the side-to-side repairs and how it is important. So now, there is the second paper from Mihata biomechanical study, which showed that a combined anterior and posterior side-to-side suturing definitely increases the stability, but decreases the ROM. So it is advised to do posterior suturing more. This is in comparison when we do on a thinner graft, like a dermal allograft. What we find is that dermal allografts stretch out more by 15%. So more stretchable the graft is, such grafts, so it is better to have anterior and posterior side-to-side suturing. And definitely, even if you suture it in dermal allografts, there's no change in the ROM. So coming to graft thickness, so it is there's a two groups here, 4 mm and 8 mm. So in the first paper, we talked about like 6 mm grafts. So here, 8 mm grafts is supposed to be better for stability. Then coming to the shoulder position, so if you look at the first papers, it was always like 45 degrees for abduction. But here we know that now 15 to 45 degrees of abduction and tightening of the graft in this particular position is excellent and gives good results. Coming to acromioplasty, so definitely acromioplasty was indicated and he used to do it on a regular basis. Why? Because definitely there will be some spurring, you have an overhanging acromion, and definitely the space would be definitely reduced. So the acromioplasty increases the space, but the acromioplasty, the final outcome of the acromioplasty would be like, definitely acromioplasty can be done and it does not affect the function and it definitely prevents future redirects. So another modification or advance would be the SCR plus. The SCR plus would be again, graft is used for the regular SCR, and on the acromion side, and another patch, the remnant patch is applied. This increases the AHD to a certain extent. So we call it SCR plus, and definitely gives us smoother surface. And then the question about, does the allografts heal? Then what happens to these? Like we know about the rotatic of healing, rotatic of vascularity. So does the vascularity increase in the, or is there vascularity in the fascial lata? So there have been Doppler studies which says that yeah, there is increased vascularity for a period of time in this fascial lata. And what about the dermal allografts? So this is one paper which showed that definitely there are tendon-like changes in an expanded graft. So about graft harvesting, so there is a little controversy earlier. We used to take the graft and used to suture the remnant, that is the fascial lata used to be, ITP used to be sutured back. It is, so if you look at the pain scores and the patient function is better if we don't suture the IT back. And there is something like, this is the another advance, like minimally invasive graft harvesting. It's supposed to be a really good technique. And this is another advance which is coming in fascial lata now. That is called as, we augment the existing grafts with a mesh. This could be a polypropylene mesh, or we can, this is the last paper is a Chinese paper, okay, which talks about a PET mesh, which is like a sandwich between, increases the graft stiffness and better outcomes. So in my technique, I have modified the techniques over a period of time from what I learned from Dr. Mihata. So what I do right now is like a hybrid. So in this hybrid, what I do is I definitely use the biceps. Dr. Ram had mentioned about the biceps SCR. So I definitely use the biceps and I combine the biceps with the regular fascial lata. This gives me lesser, the requirement of the graft size would be much lesser. So I'm not, this is what I do. So I always root the biceps and then I measure whatever the amount of graft which is required and then add on to it. And I definitely do the side to side and do a kind of, I always pass the sutures like this. So fix the biceps and then the remaining threads. So I always use triple loaded anchors, anterior and posterior in the middle row, and the lateral would be like the circles. So this is the final picture, okay. And then the side to side. So I think SCR is advancing. I think it is a very useful technique, and hopefully we'll have more literature out on it. So, thank you.